Tumors of the retina and retinal pigment epithelium today. As you can see here, retinal tumors include astrocytic tumors and vascular tumors. And RPE tumors, there are several of them. The one that you are more familiar with is congenital hypertrophy of the retinal pigment epithelium. We are going to cover some of the most important diseases. So, anybody wants to say what diagnosis we have here? So this is retinal astrocytic hamartoma. And we start with a question. Which of the following can be associated with retinal astrocytic hamartoma? One is pre-retinal or vitreous hemorrhage. 2, exudative retinal detachments. 3, vitreous seeding. 4, progressive growth.
Okay.
Well, okay. So these are benign tumors, as you know, astrocytic tumors. They have 2 types. One is the calcified type. Has a nodular yellow mulberry appearance, very typical. And then there is this non-calcified form, which is gray and sessile. These tumors are stable or very, very slowly growing. This is the typical calcified type. I mean, you see one and you never forget it. Many of them actually are located around the optic nerve head. You can see these yellow, round, calcified lesions, things inside. And when you do ultrasound, you will see that it's echo-dense. That's because of its calcium content. You see it's casting a shadow there, so it's calcified. And if you do an OCT through these lesions, you can see these round things inside, and they are highlighted on the OCT. You can see these round spaces that correspond to these. And if you do an autofluorescence test, it's hyper-autofluorescent. That's because of its calcium content, makes it hyper-autofluorescent. Fluorescein angiography, you see this is the venous phase. And on fluorescein, it's overall not very bright, but you can see some vessels inside it. This is the typical appearance of astrocytic lesions. Early, they are not very bright, but you see some vessels there. And this is actually very helpful in differentiating them from retinal capillary hemangiomas, which have a very rapid transit phase. They become bright very early. So this is a very helpful differentiating feature. Late, they show intense staining. So going back to our lesion, where is the astrocytic hamartoma? Fluorescein angiography will help. This is the tumor there. It's hyper-autofluorescent. And here, of course, it's old blood. So they can have some hemorrhage. You can see it here, and there is pre-retinal hemorrhage there. And after some time when the blood is absorbed, you are left with the tumor itself. So some of the complications that can be associated with these tumors are pre-retinal vitreous hemorrhage. You just saw that. It's rare. They can cause exudative retinal detachment, rare. They can cause even vitreous seeding. Actually, this was first reported from oncology service here, tumors that can seed into the vitreous, very rare. And they can show, in some cases, progressive growth with local invasion, again, very rare. So these are all rare complications, but they can happen. Differential diagnosis includes retinoblastoma, myelinated nerve fibers, optic disc drusen, retinal capillary hemangiomas, and fibrosis. So what is this lesion? Look at these feathery margins here, retinal superficial retina, obscuring the vessels. This is a typical myelinated nerve fiber layer, and you can see in the OCT, this is in the inner retina thickening. This one, again, it has these feathery margins there, and you can see again the typical thickening in the inner retina, and another example of myelinated nerve fiber layer. What about this one? This is a little deeper. You can see the retinal vessels there. you do an OCT, you see the retina is actually fine. This lesion is under the retina. This is actually subretinal fibrosis. And these are some features that help differentiate astrocytic tumors from retinoblastomas. So retinoblastoma typically has a feeder artery and a draining vein. Astrocytic hamartomas don't. Astrocytic hamartomas, in some cases, I told you, can have exudation, even lipid exudation, as retinoblastomas don't. These tumors can be associated with some hemorrhage, as I told you. It's very, very rare with retinoblastoma to have that. Sometimes they can have even a little traction around them. Retinoblastoma doesn't. When it comes to color, these are more grayish. These are more white. The calcification is very different. You saw that typical calcification of these lesions, this round mulberry appearance. With retinoblastoma, is this white chalky appearance. And they either don't grow or grow extremely slowly, astrocytic hamartomas, whereas retinoblastoma generally grows much faster. So what is this lesion? You see these vessels deep into it. It has feeder artery. It has draining vein. So this is a retinoblastoma. This one, again, actually, if we go back, you can actually see this white chalky calcification there, typical of retinoblastoma. This one, you don't see much calcification, but you see, again, the feeder vessels, another retinoblastoma. This one, you can talk yourself into some calcification there, again, feeder vessels, and ultrasound shows definite calcification there. So another retinoblastoma. This one, do you see any feeder vessels? There are actually these ones that deep into it. Fluorescein angiography, of course, highlights this. This is another retinoblastoma. This one, smaller, but again, you can see these vessels. This is another retinoblastoma. And this one, this is harder. You really don't see feeder vessels very obviously. But this is, again, in a patient with retinoblastoma. So this is another small retinoblastoma. Sometimes it's really hard to differentiate. And this one, you can see multiple lesions here, here, one there. You can see this one here, here. What is this one? Anybody? This is actually, you see the ultrasound doesn't show any calcium here. And this is actually in a patient with bilateral astrocytic hamartomas. Sometimes it's not really easy to tell, but those features that I told you help. And you can see that here there is hemorrhage that helps with the diagnosis. And you don't see really feeder vessels. And lack of calcium again here. So as for treatment, as I said, usually these lesions are stable, they are small, usually they are asymptomatic, nothing needs to be done. In some cases, if they are close to the fovea, they leak, they start to affect the vision. If they show progressive growth, then you have to treat them. Treatment usually is photodynamic therapy. If it's very small, laser photocoagulation. If it's peripheral, sometimes we can do cryo, but rarely necessary. They can have systemic associations. Many cases, there is no systemic association. You just have one lesion in one eye without any systemic association. Sometimes it's associated with neurofibromatosis type 1, but the most common systemic association, as you know, is tuberous sclerosis. So going back to our question, what's the answer here? All of them. So rarely. Fortunately, they are all rare. Majority of these lesions don't cause any problems. So, next question. All of the findings below are associated with tuberous sclerosis, except periungual angiofibromas, cardiac rhabdomyomas, renal angiomyolipoma, and pheochromocytoma. Okay. So let's talk about tuberous sclerosis. This is autosomal dominant. There are two genes involved. One is TSC1, chromosome 9, TSC2 on chromosome 2. Retinal astrocytic hamartomas are the most common eye feature of this condition. There is another condition that you may not be familiar with. This is called retinal achromic patch, and I'm going to show you a picture of this. Facial angiofibromas, which were called adenoma sebaceum, is another feature. Cutaneous hypopigmented lesions, they're called ash leaf, and shagreen patch of the skin, periungual angiofibroma, cardiac rhabdomyoma, renal angiomyolipoma, and as you know, they can have periventricular tumors, astrocytic tumors, which can lead to mental retardation and seizure in a significant percentage of these patients. So this is a typical lesion. You can see it's partly calcified here. There are other lesions in this eye, small ones. The other eye of the same patient, again, calcified tumor, very typical calcified, the smaller lesions here. So this patient has multiple tumors in both eyes. Obviously, this is not an isolated case. This is a patient with tuberous sclerosis. This is the retinal achromic patch. This is a picture from this article by Dr. Aronow from Wilmer. These patients can have multiple of these achromic patches in their eyes. And this is the typical angiofibroma that you can see, adenoma sebaceum, it was called in the past. Very common finding. And this is a shagreen patch. As you know, shagreen refers to a form of leather. So this has this leathery, rough appearance, these patches of skin. Usually they are seen in the lumbosacral area. So what is the significance of finding these lesions in the eye? The significance of these retinal findings, including astrocytomas and achromic patches. If you see them, the patient is at higher risk of having astrocytomas of the brain. And of course, when you have that, then there is a higher risk of having mental retardation, higher risk of having seizure, and also they are at higher risk of having renal angiomyofibromas. Lipomas, sorry. So going back to the question, what's the answer here? D. So pheochromocytomas are not typically associated with this condition. So the next lesion I'm going to talk is acquired retinal astrocytoma. It's very similar to the one we talked about with some differences. This is seen in older patients. It is not associated with tuberous sclerosis. It's solitary, just one lesion, yellow. It has some vessels that you can see inside it. It's not calcified generally. And it can show actually more growth. And it can cause more lipid exudation. So this is the acquired retinal astrocytoma. You see it's a little different. But it's causing exudation around. You can see the vessels. And you do ultrasound, it's not the typical calcified form of retinal astrocytoma, although there is very minimal suggestion of some calcium there. And we did an actually needle biopsy on this tumor, and it confirmed that it was an astrocytic lesion. On fluorescein angiography, the same thing. It's not very bright in the beginning, but it shows these fine vessels inside it. Again, this helps differentiating these lesions from capillary hemangiomas of the retina. And this is the same patient. You see the tumor there, exudation here, and this is the fovea, so it's causing vision problems. So we treated actually that with PDT. It's much smaller. The exudation is going away. Fluid is going away. Later, this tumor totally disappeared, and the patient regained 20/20 vision. So this is the next tumor we are going to talk about. This is, I think, very easy for everybody. This is the capillary hemangioma or hemangioblastoma. So which of the following is not true about retinal hemangioblastoma? Can cause distant macular exudation. Distant means that exudation is not around the tumor, but in the macula, away from the tumor. It can cause vitreous hemorrhage in the majority of cases, can be associated with vitreous traction, and can be an isolated finding with no systemic associations. So When you want to classify these tumors, you can do it in different ways. Based on location, they can be peripheral. Many of them are juxtapapillary around the optic nerve head. They can be endophytic, growing into the vitreous, on the surface of the retina, or growing deep under the retina. They can cause exudation. They can cause traction. They can have systemic associations or maybe isolated. If there are systemic associations, it's usually with VHL disease. Usually they are diagnosed around the second or third decade of life. If the patient has VHL, then usually it's seen in a younger age group. In patients with VHL, about 1/3 are multiple and 50% are bilateral. So if you see multiple, bilateral, almost always you have VHL disease. Many times you see a patient with only one retinal capillary hemangioma, and the question is, what is the risk of having VHL disease in these cases? That depends to some degree on the patient's age. If the patient is less than 10 years old, it's about half of these patients can have VHL. But if the patient continues to have only one capillary hemangioma in the eye after age 60, then the chances of having VHL is really very low, less than 1%. So the clinical features are very typical: orange-red spherical tumor. They have very dilated afferent vessels, an important feature of these. They can cause exudative retinal detachment, progressive. They can have progressive lipid exudation. They can cause remote macular hard exudation. As I said, the tumor can be in the periphery, but you can see lipid exudation in the macular area. If you see lipid exudation in the macula and you can't find the cause, of course, you can follow those dilated vessels and you can find the tumor. And they can cause vitreous traction. So that's the tractional type I told you. So this is the same patient. You can see here that the macular exudation, relatively clear area here between the macula and the tumor itself. The feeder vessel, there is actually some fibrosis, as you see on the surface of the tumor. That was the peripheral type. This is the juxtapapillary type. So this is the retinal capillary hemangioma, again causing a lot of lipid exudation there with macular edema. Compare this to the retinal astrocytic hamartoma. You can see that the difference in color, this is more red, pink, this is more yellow, but both of them can have lipid exudation. And as I said, fluorescein angiography is very helpful. Here, LE is relatively dark. This becomes bright very, very quickly. So as for diagnosis, I told you about the fluorescein, very rapid transit time, late leakage, and it's very helpful for detection of very small retinal capillary hemangiomas. Sometimes they are hard to see, but fluorescein highlights them very nicely. This is the fluorescein of the same patients. As for pathology, they are made of thin capillary vessels. They have endothelial cells. They have pericytes. But the main feature probably is these foamy stromal cells. These are actually the neoplastic cells in this condition. These are the cells that carry the genetic abnormality, not really the vessels themselves. The vessels are a secondary thing. So as for treatments, observation generally is not a good idea in these tumors. Why? Because they tend to grow and cause more problems. The bigger they become, the harder the treatments. So try to treat them when you see them, when they are very small. Rarely you may need to do observation. For instance, we had a patient that was pregnant, and we postponed the treatment for some time until after delivery. For very small tumors, you can do laser. When they get a little bigger, you can do photodynamic therapy. If they are peripheral, you can do cryotherapy. Larger tumors, plaque radiation or external beam, and some treatments, medical treatments have been tried with really not much benefit. So going back to our case, this was treated with laser and the exudation went away.
Dr. Mashaki, so you wouldn't inject with anti-VEGF if they had macular edema?
You know, actually the only benefit of anti-VEGF is for macular edema. It can help to some degree, the anti-VEGF actually I had it here. For macular edema, you can use some of these medical treatments. Usually it's a temporary thing.
For laser or cryo?
You can do, I'm glad you brought this issue up. When you treat this, let's say if it's photodynamic therapy, when you hit it with photodynamic therapy, initially the tumor starts to leak even more because you're damaging the vessels in the tumor. They are become more leaky. You can have sudden increase in the fluid. To counteract that, you can actually pre-treat the patient with anti-VEGF or even steroid. I recently treated a patient. The patient had 20/20 vision. She didn't want any treatment. She came back with 20/100 vision 2 days later because of massive exudative retinal detachment as a response to photodynamic therapy. Now it's resolving, but so
the laser in that?
you know what? Actually, again, that's a good question. I didn't want you into that. This is not really how I treat these tumors, not just around it. You have to treat the tumor itself or treat the feeder vessels to make the tumor shrink. This tumor, as you can see, was treated around the laser. The exudation went away. The tumor didn't go away. So many years later, actually, this patient came back and it was larger. So we had to treat it with a different technique later. So let's talk about the VHL disease. Retinal capillary hemangioma is considered the earliest as most common lesion associated with this condition, VHL disease. It can be seen in children that are only 2 years old, so it can be an early finding. And it can be seen in 80% of these patients by the 8th decade of life. Another feature is CNS hemangiomas. They can affect the cerebellum, brainstem, spinal cord. Renal cell carcinoma is common, and it's considered the most common cause of death in these patients. Pheochromocytoma, I remember that question that we had. So pheochromocytoma is a feature of VHL disease and not tuberous sclerosis. They can have cysts of multiple organs in the abdominal area. As for genetics, they have a germline mutation on VHL tumor suppressor gene, which is located on chromosome 3, short arm of chromosome 3. It's autosomal dominant, but remember 20% of these are new mutations, so you may have a patient with VHL and no family history, of course. The screening of these patients is important. Of course, things are changing because now we have genetic testing, which is very sensitive. But still, this screening protocol is important. For ophthalmoscopy, it has to be done once a year. And what age do you start it? You remember I told you can see these tumors in children as young as 2 years. So the suggestion is you start an annual ophthalmoscopy in infancy. MRI of the brain has to be done. Usually they start around adolescence, every 3 years, and then they move it to every 5 years later. They should have imaging of the abdomen because of the renal cell carcinoma, because of the pheochromocytoma. Usually start again around adolescence, age 16 or so. You can check the urine for VMA and for metanephrines for pheochromocytoma. But as I said, genetic testing is becoming more and more important, and it's very sensitive. So what's the answer here? Which of the following is not true about retinal hemangioblastoma? It can cause distant exudation in the macula. It can cause vitreous traction. It can be an isolated finding. Many times it's isolated, not always associated with VHL. So it doesn't cause vitreous hemorrhage. Although it's a vascular tumor, it doesn't cause vitreous hemorrhage, really. So this is the next tumor. It's very similar, actually, to retinal capillary hemangioma. The tumor is here, and you can see this massive exudation there. This one is a vasoproliferative tumor of the ocular fundus. This is a term that actually Dr. Jerry Shields coined. And the question is, which of the following is true about vasoproliferative tumor of the retina? Most are associated with pars planitis. They have dilated and tortuous feeder draining vessels. They are usually located at the optic nerve heads. They can cause exudative retinal detachments. Okay, we'll find out. So these are retinal masses, yellowish pink. They are usually located inferiorly. About half of them are actually inferotemporal. That's a typical location. They are anterior to equator, typically. They have a feeder artery and a draining vein, but remember, The feeder artery and the draining vein, in contrast to retinal capillary hemangioma, is not dilated and it's not tortuous. They can cause lipid exudation. Usually it's around the tumor, so they don't cause that distant macular exudation that I told you retinal capillary hemangiomas can do. These cause exudation around the tumor that gradually marches towards the macular area. They can cause exudative RD. These tumors sometimes cause vitreous hemorrhage. And it's very, very common for them to cause macular changes. They commonly cause epiretinal membranes. They commonly cause macular edema. So going back to this lesion, the tumor is here. You can see these fine vessels. These are actually the feeder vessel and the draining vessels. But you can see they are not dilated and they are not tortuous. This is a very important differentiating feature. And you can see that they have the exudation that is marching from the tumor going elsewhere. They don't cause that distant macular exudation. As for classification, they are divided into two types. One is the primary type, which you can see is the most common group. 75% is the primary type, doesn't have any systemic associations. These are usually one tumor in one eye. The secondary type, which is only 1/4 of cases, they can be bilateral, they can be multifocal, they can be associated with several conditions. One of them is pars planitis, retinitis pigmentosa is another one, and some other conditions, traumas and retinal detachments and so on. So how do you differentiate these two tumors, retinal capillary hemangioma and vasoproliferative? You already know all of this. Generally, these are younger, these are a little older generally. These are more posterior, these are very anterior, equator or anterior to equator. These have very dilated feeder draining vessels. They have feeder vessels, they are normal, not very dilated in caliber. They can cause remote exudation, they don't cause remote exudation. These are more red, pink, these are a little more yellow in color. These are associated with VHLs, these are not. So going back to these two, which one is which here? You know that. This one with dilated vessels, and this one without dilated vessels. This is retinal Hemangioma, and this is retinal vasoproliferative tumor. So as treatment, very similar to the retinal capillary hemangioma, basically the same techniques, although we can use observation more commonly in this group because they are not as rapidly progressive as retinal capillary hemangiomas. And this is the same tumor that I showed you after treatment, responded very nicely with resolution of the exudation. So, which of the following is true about vasoproliferative tumors? Most are associated with pars planitis. No, majority are not, are primary. They have dilated tortuous feeder vessels. They don't. They are usually located at the optic nerve head. They are not, they're peripheral. But they can cause exudative retinal detachments. So next lesion. And this is so typical. I'm sure you can guess what this is. This is the cavernous hemangioma of the retina. So which of the following tests is indicated in a patient with retinal cavernous hemangioma? A brain MRI, urine VMA, abdominal CT, and genetic testing for pre-25 deletion. So as for classification of this tumor, they can be isolated. Many times they are isolated, or they can be part of a syndrome that has CNS angiomas, which can cause problems like hemorrhage, calcification, seizure, or they can have skin angiomas. And this condition is actually autosomal dominant. It affects the CREAT1 gene on chromosome 7. The clinical features very typical, as you saw. This cluster of grape appearance of the lesions. When you look carefully, sometimes you can see the plasma erythrocyte separation in the larger sacules. They can have overlying fibroglial membrane on the surface of the tumor. Rarely they can cause vitreous hemorrhage. So see, they don't have feeder vessels, they don't cause retinal exudation, retinal detachment, they are not progressive. The only problem they can cause, hemorrhage sometimes. Usually it's mild, and it's one of those conditions that can cause subretinal, intraretinal, pre-retinal hemorrhage. And what is another condition that can do the same? Hemorrhage at all these levels. macroaneurysms of the retina are also said to cause the same thing. So going back to this lesion, you can see this cluster of grape appearance. You can see the surface gliosis. There is no retinal detachment, no lipid exudation. And you can see that it's retinal, and you can see the membrane on the OCT. Fluorescein angiography is quite diagnostic in this condition. In contrast to retinal capillary hemangioma, which has a very rapid filling of the tumor, this has a very, very slow filling. They say it almost takes up to 30 minutes for these vascular lesions to get filled with fluorescein. And you can see the fluorescein erythrocyte separation when you look. They don't cause any leakage. Another diagnostic test in these patients is CT MRI of the brain. It has to be done on the patient and sometimes on family members too, because of the association with CNS tumors. So this is the fluorescein angiography of that patient. If you look carefully, this is the fluorescein, and underneath is a little darker. This is where the blood, the erythrocytes are, and this is where the serum was, plasma, which is now filled with fluorescein. So the answer to this, I think, is very easy. Which of these is indicated in these patients? Brain MRI is, because this patient can have CNS tumors. All these abdominal CT, urine VMA, and genetic testing for 3p25 is for VHL disease. So next condition, again, typical. You know what this is. This is a racemose hemangioma of the retina. So all of the following can develop in a patient with retinal racemose hemangioma, except intracranial hemorrhage, transmission to offspring, bleeding after dental work, spontaneous epistaxis. So these lesions are congenital, and remember, they are not hereditary, okay? They are unilateral large tortuous vessels. On fluorescein angiography, they don't leak. They are usually asymptomatic. Of course, not the case I showed you. That's a very severe case. Complications are rare, but they can cause branch retinal vein occlusion, sometimes rarely vitreous hemorrhage, and if a case like ours, can actually compress the optic nerve sometimes. They can be isolated lesions, or they can be associated with Wyburn-Mason syndrome. So this is the lesion as I showed you. This is the fluorescein angiography of that case. And as for Wyburn-Mason syndrome, again, remember, it's not hereditary condition. But it can be associated, again, as I told you, for cavernous hemangioma that sometimes are associated with CNS and skin lesions, angiomas. The same is true here. They can have skin lesions, they can have CNS hemangiomas, which can rarely cause hemorrhage. In addition, they can have hemangiomas in the skull. They can have hemangiomas in the mandible and maxilla, which can cause bleeding after dental extraction or cause a spontaneous epistaxis. So again, going to the question, answer is it can cause intracranial hemorrhage when you have that angioma. It can cause bleeding after dental work and spontaneous epistaxis, but it's not hereditary, okay? So this is something that you may rarely see. It's a pigmented lesion. You can't tell from here, but it's actually like a nodule. And this is called, I think we have, formatting has changed here. This is called congenital simple hamartoma of the retinal pigment epithelium. And these are solitary nodules of RPE. They protrude through the retina into the vitreous. Very small, usually close to the fovea, generally stable. We observe them. And this is the lesion. This is the OCT. You can see how it's protruding through the retina into the vitreous, but there is no exudation around it. So generally, they're just watched. This lesion, anybody wants to guess what this is? So again, this has moved, but this is combined hamartoma of the retina and retinal pigment epithelium. Very typical appearance. The question about this condition is, all of the following are true about combined hamartoma of the retinal RPE, except can cause foveal ectopia, is unilateral, is usually stable, has familial predisposition. So, going back, I think you'll find your answer here. It's not hereditary. Again, this is not a hereditary condition. It's seen in children. It could be congenital. It's unilateral. Usually it has that ill-defined gray to brown color. It's a retinal thickening with this very typical color. It has severe surface membrane gliosis. On the surface of the lesion, you see these tortuous vessels, which probably is because of that membrane growing, causing the tortuosity. And it can cause retinal traction and severe foveal traction. Generally, it's stable, although some cases followed over time can show some progression. So this is one case. You see this color. There is membrane on the surface. There is some tortuosity of the vessels, as I said, most likely because of the membrane. And you can see that it's retinal lesion. The thickening is seen well. This is the case I showed you. Again, look at this typical color, typical for combined hamartoma. You can see the fibrosis, the traction, the foveal ectopia. So they can have, usually they don't have any systemic associations. Some systemic associations have been reported, but these are very rare. Generally, they don't have any systemic associations. The most important probably is neurofibromatosis. So if you see one of these, definitely check the patient for neurofibromatosis. So this is another RPE tumor. This is very rare. I'm just showing this for you because it looks like a melanoma. You can see it has a typical brown color. But there are certain things that are different, and I'm going to emphasize that. This is an adenoma of the retinal pigment epithelium. Well, the question is, which of the following features is more likely to be seen with adenoma of the RPE compared to choroidal melanoma? Presence of feeder draining vessels, lipid exudation, cystoid macular edema, all of the above. So, RPE adenomas are generally solitary, unilateral, very dark brown to black. They can show a slow growth. And they eventually, because they are just under the retina, from RPE, they come and grow into the retina. They have retinal feeding artery and a draining vein. Okay, so this is a difference with melanoma. They can cause massive lipid exudation and exudative retinal detachment, and they very, very commonly cause cystoid macular edema. So going back to this lesion, the feeder vessel is not very easily seen here, but you can see the massive exudation. And you can see it is very solid on ultrasound. You remember that choroidal melanoma generally are acoustically hollow inside. This one is very solid. And you can see that this case actually already has the cystoid macular edema. And the fluorescein shows actually the vessels that are feeding and draining it. RPE adenomas generally are isolated findings, but they can develop secondary to RPE hyperplasia. For instance, we have seen them develop in an area where there was scarring from prior laser treatments. And we have seen this develop over congenital hypertrophy of the retinal pigment epithelium. So the differences, RPE adenoma is very dark, usually less dark. They have lipid exudation, melanomas don't. They have feeding draining vessels, melanomas don't. They have a medium to high internal reflectivity on ultrasound. These are usually more hollow. These are commonly called CME. CME is rare with melanoma. So this is a melanoma. I just show this just for comparison. It can be dark, but it's a little less dark. And this is the ultrasound of the melanoma. You see it's not as dense. It's a little more hollow inside. Okay, now we go to the next lesion of the RPE. This is very easy, although it's a kind of unusual dramatic case. But this is a congenital hypertrophy of the retinal pigment epithelium. Which of the following is false about this condition? Most solitary CHRPE show a slow growth. Solitary CHRPE is associated with overlying retinal atrophy. Multifocal CHRPE can be associated with higher incidence of colon cancer. And multifocal CHRPE is not hereditary. So as for classification, we are divide CHRPE into solitary and multifocal. Multifocal is also referred to as congenital grouped pigmentation or bare tracks. And remember, neither of these should be confused with the RPE lesions that are associated with familial adenomatous polyposis. These are really different. In the literature, you will see that these lesions are referred to as CHRPE, but this is really a mistake. These are different. Solitary CHRPE usually is seen in adults. It has very sharply demarcated margins. It's flat. Usually it's pigmented, but it can be non-pigmented in some cases. Generally, it has these amelanotic spaces inside that are referred to as lacunae. And generally, it has a pigmented halo around it. The testing that we do on ultrasound confirms that it's flat. If you do visual field examination, you can see a defect which corresponds to the location of that CHRPE. On OCT, you will see overlying retinal atrophy. The outer retina becomes atrophic in this condition. On histopathology, they have RPE hypertrophy, sometimes even RPE hyperplasia. They have large spherical melanosomes, and histopathology, of course, shows the overlying RPE atrophy too. So I'm going to show you a few examples. CHRPE, you can see the sharp margin, the pigmented halo around it. Very actually important feature, this pigmented halo. Sometimes helps with differential diagnosis. The lacunae inside. This is similar, except that the lacunae is actually filling the whole thing. That's why it's amelanotic. So when you see an amelanotic CHRPE, really it had a lacunae that has now completely filled the whole thing. But you still can see this pigmented halo around it. So this solitary CHRPE, based on a study we did here, they show very slow enlargement over time. Actually, the majority of the lesions we followed over time, they did grow, but it's very slow growth. And the lacunae inside them also over time get bigger and bigger. So this is a congenital CHRPE here, and years later, you can see the difference. It has really grown. So they can grow, and majority of them do. They can also cause nodular growths on top of them. These nodular growths, I told you about RPE adenomas that they can develop over CHRPE. It's the same thing. You can develop RPE adenomas. Again, this was first described by Dr. Jerry Shields here. So this is a CHRPE, and look at this round thing on the surface. This is the RPE adenoma developing there. You can also see it on the ultrasound. This is another example of a CHRPE here, and then this nodule is developing there. You can already see a little exudation around it, although it's small. And the fluorescein actually highlights here the adenoma. So this is, again, just to compare CHRPE with a large choroidal nevus or a small choroidal melanoma. You can see very sharp margins. It has that pigmented halo, less defined margins, no halos there. So multifocal CHRPEs is also referred to, as I said, as congenital group pigmentation or bare tracks. Remember, these are not hereditary. They are not associated with ocular or systemic findings. They are usually small, flat, usually involve one sector of the ocular fundus. And when they are in a sector, a group of them, usually the larger lesions are located more peripheral. So this is an example in the two eyes of the same patient. Multiple here, here. You can see the larger lesions in every group are more peripheral. Again, don't confuse this with the lesions that are associated with Gardner syndrome or polyposis. So the question, which of the following is false? Most solitary CHRPE grow, this is true. Solitary CHRPE is associated with overlying RPE atrophy is true. Multifocal CHRPE can be associated with high risk of colon cancer, obviously false. And multifocal CHRPE is not hereditary, true. So this is what we were talking about. These are the lesions that are associated with polyposis. And we call them RPE hamartomas associated with familial polyposis. These are not CHRPE, as I said. If you have them, usually in patients with this condition, there are multiple of them. They say you should have usually 4 or more of them. They are bilateral generally. They don't have a sector distribution in contrast to the group pigmentation of the multifocal CHRPEs. They have this adjacent halo of the pigmentation, and they have a tail of the pigmentation that points towards the optic disc. And this lesion shows them very nice. You see this halo of the pigmentation, and they have this tail that points towards the optic disc. And if you do fluorescein, actually it highlights them. You can actually see there are probably more lesions in this area. Again, this eye probably has very tiny lesions too. So this is the last condition we're going to talk about. This is the familial adenomatous polyposis. It's an autosomal dominant condition. They have a mutation in the APC gene on chromosome 5. They are associated with RPE hamartoma that I showed you in majority of cases, but not all of them. And this patient, as you know, developed colon cancer, almost everybody by age 40. And the two conditions, syndromes associated, you know these two, Gardner syndrome and Turcot syndrome, which is this with CNS glioma. So that's the end of the talk. Do you have any questions? Thank you. Sorry? You know what? I didn't make one, but we can give you one.
That would be very,
So,
very helpful.
oh, definitely.